Hi, this is Brian Kim. I'm going to share with you case number 152 in the Best Way to Do Cataract Surgery series. This is a 3 to 4 plus dense lens. You're going to see I'm going to do the terminal chop by sculpting a small short groove, and then by debulking the lens, I'm able to perform then the terminal chop maneuver, fracturing from the equatorial side, propagating the chop all the way through, and then performing cross chop and mechanical fracturing techniques. Again, methodical lens disassembly, sparing CDE for clearer corneas in these dense lenses. So this is the eye. I'm using a cotton tip to steady and center the eye, and then using a corneal marker, which will help me to center and size the rhexis. It's really important when you're doing these maneuvers to keep the eye facing straight up and down, otherwise your marks will be off. I make a paracentesis incision first on the right side and then the left side, making sure I'm parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral lidocaine, and then some intracameral epinephrine, and then now some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, turn the eye towards me when I'm ready to enter, and I go in. So these are the Haldey-Perkar forceps. Puncture the center. These are the blunt tip forceps, and so I don't perseverate, I don't push down too hard here. Then I switch to the cystotome. I puncture with the cystotome and create a little bit of a flap there. This is an older case, obviously, because I have the sharp tip Haldey-Perkars now. So grab the right side of the tear going around circumferentially. Very carefully going around circumferentially, trying to align my rhexis with the previous corneal mark that I made. Again, you can see very controlled, very confident, minimal viscoelastic egress. Finish off the rhexis, burp some viscoelastic out. This is a Capsulorhexis hydrodissection technique. I place the cannula under the rhexis edge, contra-incisionally. Point the tip down, get a nice wave. Very carefully try to decompress. Again, this is a dense lens, so sometimes you can have a little bit of capsular block, but here I'm able to very gently hook the peripheral lens on the right side and the lens begins to spin. Irrigating the surface of the eye, lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma. Removing the surface epinuchal material. Now I'm rotating the bevel up and I'm switching to sculpt mode and start to sculpt a fairly short trough there because all I'm trying to do is debulk the center. I don't really care about the periphery because I know I can fracture the peripheral lens pretty easily. Again, not super dense, that's why I switch here. Go back to quad mode, and here we go. I'm pronating my hand. I have the tip pointed out to the periphery. The chopper end is fairly flat to the lens surface. I'm gliding it out underneath the rhexis edge, and as I do that, I supinate my hand, and now the tip is pointed straight up and down, but slightly towards me. You can see the tip through the lens there, and then I'm going to bring that phaco tip towards that terminal area, fracturing that terminal aspect of the lens peripherally. By doing it this way, I'm able to propagate that fracture all the way through and through. And again, this is the way you can minimize getting a posterior plate. You saw I moved the chopper towards me, underneath me, and I'm able to fracture the lens material through and through, all the way propagating from distal all the way proximal. I placed the chopper underneath the rhexis edge contra-incisionally on the right side, and I turn the chopper again straight up and down. I pull the chopper towards me, and it fractures the lens against the phaco tip, and that is the cross chop. Placing the instruments around that first quadrant and fracturing the lens completely in half, lifting it up with a little bit of vacuum, And again, in slow motion, you can see I'm just fracturing the lens, crushing the lens between the instruments over and over and over again. Because this is a dense lens, it's a little bit more tedious to break up the lens between the instruments, but that's when you can pulse between using ultrasonic energy and vacuum to emulsify the lens piece as you go. Again, pronating my hand, getting under the rhexis edge, supinating again so the chopper is pointed up and down, pulling the chopper towards the phaco tip, fracturing that second quadrant, using some vacuum to grab the lens piece, and then sandwiching the lens between the instruments. Doing the same maneuver over again, crushing the lens into smaller pieces, and then emulsifying the lens piece. I'm rotating the second heminucleus in front of me now, placing the chopper underneath the rhexis edge contra-incisionally, having the phaco tip positions deep in the bag, fracturing the lens completely in half, sandwiching the lens piece, placing the chopper around that third quadrant, performing the same exact maneuver, pulling it centrally toward the phaco tip, fracturing that third quadrant in half, lifting that fragment up with some vacuum, positioning it on the tip, and then crushing the lens between the instruments. Crushing it again into smaller pieces and then emulsifying the lens piece, grabbing that fragment up out of the bag, fracturing the lens again using mechanical forces only. Whenever I'm fracturing the lens, I'm not utilizing any vacuum or ultrasonic energy, which makes things easy and safer because I'm not utilizing ultrasonic energy unnecessarily, and I'm not using the vacuum haphazardly as well. Getting the chopper around that last quadrant, hooking the peripheral lens, and then crushing the lens between the instruments, crushing the lens again and again into smaller pieces before I emulsify it. And again, when I'm crushing the lens, I'm not utilizing ultrasonic energy or vacuum. Again, I think this is a very systematic, thoughtful way to break down the lens. I'm able to use crushing forces rather than using ultrasonic energy or vacuum. But then when I'm ready to emulsify, of course, I use pulses of ultrasonic energy and vacuum to remove the lens pieces from the eye. Again, here using some vacuum to position the lens piece on the tip, and then crushing the lens piece between the instruments, and then emulsifying the lens piece. And here are the last fragments. I have a pretty robust epinuclear shell, and that's why I'm very confident. I'm not worried about the posterior capsule coming up in this particular situation. But in some cases, you don't have much protection, so you have to keep that chopper deep in the bag. So now the epinucleus is coming out, and it's collapsing into the tip. Again, being very careful when I'm moving the epinucleus to protect that posterior capsule with the chopper. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the ironing handpiece. Start subincisionally, removing the cortical material. Switch to polish mode, polishing underneath the rhexis edge. With these dense lenses, I always worry about zonulopathy, so you want to be somewhat careful around the capsule and not apply any stress on the zonules when you're doing these maneuvers. So polish mode is just really advantageous because it has the lower settings. You can't grab the capsular bag or the zonules this way. Using the cannula to pulse into the subincisional capsule fornix, you can see there's some lens material that's being liberated there. Switch to cortex mode, removing the rest of that material. Pushing cohesive viscoelastic to fill the capsular bag. And this is a sweep. And this is just a minor point, but you can see there's no wasted steps when I do the cataract surgery. You know, compared to when you're in residency and you have no idea kind of what to do next. When you're doing cataract surgery, you should be anticipating every next move, and your right hand and left hand should be working in harmony and synchronously so that you're advancing throughout the case. So I widen the incision, and this is a 3-piece lens. I go in and then turn the bevel to the left. This allows the leading haptic to come out flat into the capsular bag. As the optic comes out, I start to pronate my right hand so that the optic comes out flat. Using the multimeter to dial the trailing haptic into the bag, go in with irrigation off with the INA handpiece. Going underneath the optic, removing the viscoelastic from within the bag. Repositing the optic back, polishing underneath the rhexis edge. Switching to visco mode, removing the viscoelastic from within the anterior chamber, and then I'll hydrate my incision. So again, this is terminal chop. This is a dense lens. I'm able to make a short groove. The point of that is to debulk most of that mass so that I'm able to get a through and through propagation of the fracturing of the lens. If I don't do that, you're going to end up with this posterior plate because the fracture point is too superficial. And so you'll get this Pac-Man effect where you're fractured the top part of the lens, but you haven't gone through and through. So because the lens in cross-section is more kind of roundish, the thickest part is going to be towards the center. And so that's why you attack that thickest part in the center by creating a groove. I'm able to, even if it's just halfway through with the groove, you don't have to go all the way down to the posterior capsule. By debulking it even just halfway, I then am able to place the chopper, pronating my hand, getting underneath the rhexis edge, making sure the tip of the chopper is flat, and then I supinate my hand, rotating it so the chopper is pointed up and down, but slightly towards me. And then I'm able to crush that terminal aspect of that lens material, fracturing it. By fracturing it, I'm able to propagate that fracture point from the periphery all the way down into the posterior aspect of the lens. It fractures the lens completely in half. I'm able to separate it completely in this case, and then go around the right heminucleus, pulling it centrally towards the fake tip, fracturing the right heminucleus completely in half, and then using successive crushing forces to carefully and systematically disassemble the lens. This patient did well. And again, considering this very dense lens, this patient had a nice clear cornea postoperatively. This is why I prefer to perform mechanical fracturing techniques in these dense lenses. So I hope this was helpful to you, and I thank you for your attention.